Pre-manipulative tests for the thoracic spine. Thoracic spine-related pain syndromes occur far less frequently compared to the cervical or lumbar regions. According to McKenzie and May, 2006, only about 5 to 17% of spinal complaints originate from the thoracic area. Often, thoracic discomfort stems from visceral conditions, although musculoskeletal issues within the region are also commonly encountered. Some of the primary disorders seen in this part of the spine include kyphosis, scoliosis, ankylosing spondylitis, osteoarthritis, juvenile kyphosis, thoracic nerve fibromas, Paget's disease, and spinal tuberculosis, Ombrecht, 2013. Accurate diagnosis and effective management of thoracic spine disorders can be difficult due to a lack of robust, high-quality research in this area, Lemoli et al., 2002. Despite this limitation, clinicians often rely on several specific diagnostic procedures designed to evaluate thoracic spine conditions, outlined in Table 5.3. Pre-manipulative screening for the lumbar spine. Low back pain is one of the most widespread health complaints globally, affecting nearly everyone at some point. Its causes are diverse and can range from conditions such as lumbar osteoarthritis and spondylolisthesis to disc herniations, lumbar instability, degenerative disc disease, spinal stenosis, and various injuries, including those that trap spinal nerves, Juniper, Lee, and Latzi, 2009. Therefore, before proceeding with spinal manipulation therapy, SMT, targeting the lumbar spine, it is essential that clinicians precisely identify the underlying cause of the patient's symptoms. Several specialized tests are used during the screening phase to aid in diagnosis. See Table 5.4. Among them, the straight leg raise and the slump test are two of the most widely used for identifying lumbar disc herniations. Majlisi et al., 2008. Evaluating the safety of SMT for lumbar disc conditions. Spinal manipulation, when executed properly by trained professionals, is largely considered a safe method for treating musculoskeletal issues. The most frequently reported negative reactions are temporary symptom flare-ups or mild new local discomfort. Severe complications are rare, though isolated cases involving lumbar disc annular tears, LDA, lumbar disc herniation, LDH, and degenerative disc disease, DDD, have been documented in scientific literature. Boucher and Robidoux, 2014. On the flip side, a growing body of research supports spinal manipulation as a safe and effective method for treating both acute and chronic discogenic low back pain, DLBP, Oliphant, 2004. Thus, it becomes important to assess whether the potential benefits of SMT outweigh its risks. This is a fundamental part of modern clinical practice and informed consent, where evidence-based decision-making is used to weigh risk-to-benefit ratios. This same principle can be applied to SMT as a treatment strategy for DLBP. To determine the real risk of serious complications, like Cotta-Equina syndrome, CES, LDAT, or LDH, researchers often analyze data from published adverse event reports in relation to the total number of patients treated with SMT. While it's extremely challenging to calculate this risk globally, it becomes more feasible.
So your back hurts? I'm a chiro.
For instance,
I'll show you
chiropractic
how
in the
to
United
stretch
States, being the largest
Sit
group
up,
performing
hands
lumbar
up,
SMT
squeeze it.
worldwide, offer
Hold
a
it,
representative
then
data set for
release it.
estimating associated
Repeat
risks.
it.
However,
I'm a
it's
chiro.
important to note that adverse event data in some studies include cases from a broad range of practitioners, surgeons, physiotherapists, massage therapists, and even unqualified individuals, making it difficult to isolate the risks specifically linked to trained chiropractors. Risk versus benefit, lumbar spinal manipulation. To properly assess the risks of lumbar SMT, researchers often disregard minor, short-lived side effects and instead focus on serious adverse outcomes. By comparing the number of reported serious complications with the estimated number of SMT recipients, a risk estimate can be made. Authors like Adams and Sim, 1998, Cagney et al., 2004, and Smith et al., 1995, have attempted such estimations. However, the results vary widely, and a definitive complication rate is still undetermined. According to chiropractic literature, the rate of serious complications, such as LDH, LDAT, and CES following lumbar SMT, is as low as 1 in 3.7 million, Oliphant, 2004. This risk appears to double when manipulation is performed under anesthesia, Haldeman and Rubenstein, 1992. Reviewing chiropractic patient data spanning 40 years in the U.S., Oliphant estimated that complications like CES or LDH occurred in only 1 out of 46 million patients with DLBP. An earlier estimate by Haldeman and Rubenstein in 1992 placed the risk of CES at 1 in 286 million procedures. To further contextualize these figures, some researchers have compared conventional treatments like NSAIDs and spinal fusion surgery. NSAIDs, while commonly used, lead to serious complications. Gastrointestinal bleeding. Coulter, 1998, argued that lumbar manipulation is considerably safer, as NSAID use results in about 3.2 complications per 1,000 users.